Welcome to another episode of MedScroll Clinical Case Files, where we bring real-world complexity into sharp clinical focus, one long case at a time. In this episode, we meet Ms. Martha Hughes, a 66-year-old woman with long-standing type 2 diabetes mellitus, presenting with chronic diarrhoea, progressive frailty, and a background of macrovascular and microvascular complications. Her story weaves together a tapestry of diabetic nephropathy, ischemic heart disease, peripheral and autonomic neuropathy, and social vulnerability that challenges even the most seasoned clinician. Join us as we explore this nuanced RACP-style long case. From a candidate's full case presentation through to structured examiner discussion, model answers and reflections on multidisciplinary care, advanced planning and patient-centered management. So, grab your stethoscope. Let's walk through the clinical reasoning that transforms complexity into clarity.
Today, I present the case of Ms. Martha Hughes, a 66-year-old European woman with long-standing type 2 diabetes mellitus, who presents with progressive functional decline and chronic diarrhea. Her case is complicated by extensive microvascular and macrovascular complications, as well as comorbid conditions, including stage 3B chronic kidney disease, ischemic heart disease, chronic obstructive pulmonary disease, and osteoporosis. Ms. Hughes was diagnosed with type 2 diabetes at the age of 42 during routine health screening. Initially, her diabetes was managed with diet and oral hypoglycemics. However, due to progressive deterioration in glycemic control, she was transitioned to insulin therapy by the age of 55. She now follows a basal bolus insulin regimen with insulin glargine 28 units at night and variable dose insulin aspart with meals. She continues to take extended-release metformin at 1 gram daily, which has been tolerated despite declining renal function. Her latest HbA1c is 7.6%, and her fasting blood glucose levels range between 6 to 9 millimoles per liter. There is a strong family history of diabetes. Both her parents were affected. She is adherent with her treatment plan and engages regularly with her diabetes educator and allied health team. Macrovascular complications include a history of ischemic heart disease. She had a non-ST elevation myocardial infarction at age 61, and coronary angiography at that time revealed single-vessel LAD disease. She underwent percutaneous coronary intervention with stenting. Since then, her angina has been stable on medical therapy with aspirin, statin, and antihypertensive agents. She has not reported any recent chest pain, although her exercise capacity is limited by fatigue and neuropathy. In terms of microvascular complications, she has established diabetic nephropathy. Her most recent estimated glomerular filtration rate is 38 milliliters per minute per 1.73 square meters, and her urine albumin to creatinine ratio is 12 milligrams per millimole. There is no hematuria. Renal ultrasound shows bilaterally small echogenic kidneys. She is on perindopril and a SGLT2 inhibitor for renoprotection. While her renal function has remained relatively stable, she is under nephrology follow-up and has been deemed unsuitable for transplantation due to cardiovascular comorbidity and frailty. She also has peripheral neuropathy affecting both feet in a stocking distribution. This manifests as numbness, burning sensations, and impaired proprioception. Her symptoms are managed with pregabalin 75 milligrams nocte. Examination revealed absent ankle reflexes and a positive Romberg sign. In addition, she has non-proliferative diabetic retinopathy, diagnosed 5 years ago and treated with laser photocoagulation 3 years ago. She continues to attend annual ophthalmology reviews. A key feature of her presentation is symptomatic autonomic neuropathy. This includes significant orthostatic hypertension, as well as chronic diarrhea, which has been ongoing for over 18 months. She reports 3 to 5 loose bowel movements daily, not associated with blood, mucus, weight loss, or nocturnal symptoms. Gastroenterology evaluation, including stool cultures, celiac screen, and colonoscopy, were unremarkable. Bile acid diarrhea and diabetic enteropathy are considered likely. She has trialed bile acid binders and loperamide, with partial improvement. Ms. Hughes also has stage 3B chronic kidney disease. This has been stable over the last 12 months, but places her at risk of progressive renal decline. She is not considered suitable for dialysis or transplantation due to comorbidities and functional status. There have been preliminary discussions around goals of care, but no formalized advanced care plan. Her cardiac history includes well-controlled hypertension on triple therapy and hyperlipidemia. She is on perindopril, dapagliflozin, and atorvastatin 40 mg nocte. Her LDL is 1.7 millimoles per liter. She remains on aspirin monotherapy following her PCI. Respiratory comorbidity includes COPD, diagnosed 6 years ago. She is a former smoker with a 30-pack-year history, quitting 6 years ago. She completed pulmonary rehabilitation last year and remains on tiotropium/olodaterol dry powder inhaler. Her symptoms are mild and well controlled. She also has osteoporosis, diagnosed 2 years ago following a fragility fracture of the wrist. A DEXA scan showed a lumbar spine T-score of -2.9. She is currently receiving denosumab every 6 months and takes daily calcium carbonate and cholecalciferol. She has not had further fractures. A home safety review has been performed, and she uses a walker for mobility. Functionally, Ms. Hughes is declining. She lives alone in public housing and is divorced. Her 2 adult children live interstate and provide only telephone support. She retired at age 60 from her role as a school secretary due to health issues. She uses a walking frame for ambulation and reports significant fatigue. She receives a support worker twice weekly through My Aged Care. She has missed some appointments due to mobility and transport limitations. She expresses anxiety about losing her independence and fears that she may need to transition to residential care. She has a history of generalized anxiety disorder, currently well managed on sertraline 50 mg daily. On physical examination, she appeared overweight and fatigued. She mobilized slowly with a walking frame. Her blood pressure was 110/65 millimeters of mercury lying, dropping to 90/55 millimeters of mercury standing, with associated lightheadedness. Heart rate was 76 beats per minute, and oxygen saturation was 96% on room air. Cardiovascular examination was unremarkable, with dual heart sounds and no murmurs. Respiratory examination revealed mild expiratory wheeze without crackles. Her abdomen was soft and mildly tender without organomegaly. Neurological examination confirmed absent ankle reflexes, reduced vibration and proprioception to the mid-shin, and a positive Romberg sign. In summary, Ms. Hughes presents with complex, long-standing type 2 diabetes mellitus complicated by multiple microvascular and macrovascular complications. These include diabetic nephropathy with stage 3B chronic kidney disease, peripheral and autonomic neuropathy, diabetic retinopathy, and a history of ischemic heart disease. Her autonomic dysfunction is notable for postural hypotension and chronic diarrhea. She also has COPD and osteoporosis, and is experiencing progressive frailty, functional decline, and psychosocial vulnerability. My problem list includes type 2 diabetes mellitus with macrovascular IHD and microvascular complications, nephropathy, neuropathy, retinopathy, autonomic neuropathy with chronic diarrhea and postural hypotension. Chronic kidney disease stage 3B, ischemic heart disease, post-end STEMI with LAD stent, COPD, GOLD2, osteoporosis with fragility fracture, functional decline and social vulnerability. In terms of management, for diabetes, I would continue her basal bolus insulin regimen with monitoring for hypoglycemia particularly in the setting of renal impairment. Her metformin can be continued cautiously given stable eGFR. I would continue to engage allied health, including a diabetes educator, podiatrist, and dietitian. Annual foot and eye assessments are being maintained. For autonomic neuropathy and diarrhoea, I would continue symptomatic treatment with anti-motility agents and trial empirical cholestyramine if bile acid diarrhea remains suspected. Further gastroenterology review may be warranted if symptoms worsen. For her CKD, I would continue ACE inhibitor and SGLT2 inhibitor for renal protection, monitor renal function and electrolytes every 3 to 6 months, and avoid nephrotoxins. Early advanced care planning discussions should be revisited. Her IHD requires continuation of aspirin and statin, as well as antihypertensives to target. Symptoms remain stable, and she is under regular cardiology follow-up. For COPD, I would maintain current inhalers, encourage pulmonary rehab maintenance, and provide annual influenza and pneumococcal vaccinations. Osteoporosis is managed with denosumab, calcium and vitamin D, and fall prevention strategies through occupational therapy and home safety review. Lastly, her social and functional decline necessitate a multidisciplinary approach, including social work, physiotherapy, and occupational therapy. I would ensure that her My Aged Care plan meets her current needs and consider a geriatrician review if her independence continues to deteriorate. This case highlights the complex interplay of long-term diabetes complications, comorbid chronic disease, and social vulnerability. My focus would be on integrated, multidisciplinary care to optimize function, minimize complications, and support patient-centered planning.
Can you elaborate on the differential diagnoses for her chronic diarrhea?
Certainly. In this patient, the chronic diarrhea is most likely due to diabetic autonomic neuropathy, commonly termed diabetic enteropathy. It tends to be painless, watery, and may be associated with nocturnal symptoms. Given the absence of red flags such as weight loss, bleeding, or systemic signs, and in the context of long-standing diabetes with other autonomic features like orthostatic hypotension, this fits the clinical picture. Other differentials I've considered include bile acid malabsorption, which may occur independently or be part of autonomic dysfunction. A therapeutic trial of cholestyramine may be both diagnostic and therapeutic. Small intestinal bacterial overgrowth, SIBO, which is more common in diabetics due to reduced motility. Microscopic colitis and celiac disease have been excluded via colonoscopy and serology respectively. Laxative overuse has been excluded by history, and there are no signs of infection. Her negative colonoscopy and response to symptomatic management support a functional cause, likely diabetic autonomic neuropathy.
How would you manage her chronic diarrhea?
I would begin with lifestyle and dietary adjustments. Small, low-fiber, low-fat meals to improve motility. Pharmacologically, loperamide is already in use and can be titrated. A trial of cholestyramine would be appropriate to rule out bile acid diarrhea. If SIBO is suspected, a course of rifaximin could be trialed empirically if hydrogen breath testing is not accessible. Probiotics and stool bulking agents may also offer symptomatic relief. If symptoms persist despite these measures, I would re-refer to gastroenterology for potential further workup, including capsule endoscopy or motility studies.
What are your goals in managing her chronic kidney disease?
My main goals are to slow the progression of CKD, manage complications, avoid nephrotoxins and unnecessary hospital admissions, engage in early discussions around renal replacement therapy planning, where appropriate. She's already on an ACE inhibitor and an SGLT2 inhibitor, both of which provide renal protection. Her blood pressure is well controlled, and she avoids NSAIDs. I would monitor UECs and ACR every 3 to 6 months. Anemia and mineral bone disease monitoring are also important. Finally, given her frailty and cardiovascular comorbidities, she is unlikely to be a candidate for transplant or dialysis, so supportive management and advanced care planning are central.
How would you assess her risk of foot complications?
Foot complications in diabetes arise from neuropathy, ischemia, and structural deformities. In Ms. Hughes, she has established peripheral neuropathy. On examination, she has loss of protective sensation. She has no history of foot ulcers, and her skin is currently intact. I would formally assess her feet using monofilament testing, vibration sensation, pedal pulses, and inspect for deformities or callus formation. She is at moderate risk due to sensory loss and should remain under regular podiatry review, ideally every 3 to 6 months, and receive education on daily foot checks and appropriate footwear.
How would you address her risk of hypoglycemia, particularly with her insulin use?
She is at increased risk of hypoglycemia due to insulin use, renal impairment, and variable oral intake secondary to diarrhea. Management would include reviewing her insulin regimen, reduce insulin doses if morning lows occur. Consider involving a diabetes nurse to optimize timing and dose of her rapid-acting insulin. Provide hypoglycemia education and ensure she has access to glucose rescue strategies. Regular blood glucose monitoring and involvement of her GP and diabetes educator would help ensure safety. Given her functional decline, simplifying her regimen with a potential shift towards a once-daily basal insulin approach may be considered in the future.
What would you consider in future planning for her CKD if her function deteriorated?
As she is not a transplant candidate and has frailty with poor functional reserve, conservative management of ESKD is likely to be the most appropriate path. This involves symptom-based treatment, avoidance of burdensome interventions, management of fluid overload, anemia, and acidosis, ensuring clear advanced care planning and documentation of resuscitation preferences. I would ensure these discussions are held early and reviewed regularly, ideally involving her GP and nephrology team, with potential input from palliative care.
What are the cardiovascular risk considerations in her case?
Ms. Hughes has several cardiovascular risk factors: type 2 diabetes, CKD, IHD, dyslipidemia, and a history of smoking. She is on optimal secondary prevention, including aspirin, statin, ACE inhibitor, and SGLT2 inhibitor. Blood pressure is controlled. LDL is at goal. Lifestyle factors, diet and activity, remain challenging due to fatigue, neuropathy, and functional decline. Continued cardiology review, monitoring of angina symptoms, and consideration of repeat echo or stress testing if symptoms change would be appropriate.
How would you approach the psychosocial aspects of her care?
Ms. Hughes lives alone, has limited family support, and expresses concern about future independence. She's reliant on a support worker and has transport barriers affecting clinic attendance. I would engage social work for assessment of support services and possible increase in my aged care hours. Screen for depression and anxiety formally. Encourage ongoing mental health support via GP or psychologist. Consider geriatrician input for comprehensive assessment. Discuss future planning, including enduring guardianship and residential care if needed. The goal is to maintain independence and quality of life as long as possible, with coordinated, multidisciplinary input.
How would you assess her overall functional status, and how does that influence your management?
Ms. Hughes exhibits progressive functional decline. She uses a walking frame, experiences fatigue, and is limited by peripheral neuropathy and orthostatic hypotension. She struggles with activities outside the home and requires assistance from a support worker twice weekly. From a functional standpoint, I would classify her as having reduced reserve with borderline independence in instrumental ADLs. This significantly influences my management. I would prioritize interventions that preserve function, such as falls prevention, physical therapy, and occupational therapy input. It also means I need to take a conservative approach to complex or burdensome treatments, ensure realistic goal setting, and initiate early discussions about advanced care planning.
How would you counsel her about the long-term trajectory of her CKD and what to expect?
I would explain that her CKD is currently stable at stage 3B, but carries a risk of progression, particularly given her age, diabetes, and vascular comorbidities. I would emphasize the importance of continued blood pressure and glycemic control, as well as avoidance of nephrotoxic medications. Given her overall frailty and comorbidities, I would explain that should she progress to end-stage renal failure, dialysis may not offer survival or quality of life benefits. Instead, we would focus on symptom control and supportive care. I would involve the nephrologist in these discussions and encourage family participation if agreeable to her.
What are the key strategies you would use to prevent further falls or fractures?
Her history of a fragility fracture and positive Romberg test suggest high risk. My key strategies would include maintaining her current osteoporosis therapy, denosumab, calcium, and vitamin D, home safety assessment via occupational therapy to reduce environmental risks, physiotherapy for strength, balance, and mobility training, addressing orthostatic hypertension by reviewing antihypertensives, encouraging fluid intake, and possibly adding compression stockings, ensuring visual assessments are up to date, and reviewing footwear, avoiding medications that could worsen postural symptoms or sedation.
What considerations would you take into account before stopping metformin in this patient?
Her eGFR is 38, so current guidelines permit cautious continuation of metformin. However, if her renal function deteriorates further, eGFR less than 30, or if she experiences acute illness or dehydration, metformin should be withheld to avoid lactic acidosis. I would monitor renal function regularly and educate her on sick day management. If stopped, I would consider whether insulin dose adjustment or addition of another agent, if safe, is warranted.
Would you consider deprescribing any of her medications?
Yes, deprescribing is appropriate given her polypharmacy and frailty. I would review each medication for ongoing indication, potential harm, and benefit. Sertraline is appropriate in stabilizing her mood. Dapagliflozin provides cardiovascular and renal benefits, but may need review if her eGFR falls further. Aspirin can be continued given her IHD history. If she begins to experience more hypoglycemic episodes, we may simplify her insulin regimen. Pregabalin is useful for neuropathic pain, but its sedation and fall risk need review. Regular medication reconciliation and input from her pharmacist or GP would support safe deprescribing.
What role would palliative care play in this patient's journey?
Palliative care would play a crucial role in addressing symptom burden, especially chronic diarrhea, fatigue, neuropathic pain, and anxiety about decline. They could assist in coordinating care, provide support to avoid hospitalizations, and help with advanced care planning. While she is not imminently dying, her frailty, comorbidities, and progressive loss of independence warrant early palliative involvement for quality of life-focused care.
How would you approach the discussion around residential care with her?
I would first explore her understanding and feelings about her current limitations and what support she has at home. I would frame the conversation around maintaining her independence and quality of life for as long as possible, but discuss residential care as a future option should her needs exceed what can be provided at home. I'd ensure she knows this is not a forced pathway, involve her GP and social worker, and ideally include her family in decision-making. The discussion would be paced, sensitive, and reviewed over time.
Would you consider geriatrician input, and why?
Absolutely. A geriatrician could provide a comprehensive assessment covering her physical, cognitive, psychological, social, and medication domains. This would help guide care planning, support decisions about residential care, and ensure all aspects of her functional decline are addressed. They can also coordinate falls prevention, frailty management, and review the need for allied health services, particularly as she enters a stage of increased care needs.
That wraps up today's episode of MedScroll Clinical Case Files. We hope this deep dive into complex patient care has sharpened your clinical lens and sparked new reflections on long case strategy. If you found this case valuable, consider subscribing, liking, or sharing it with colleagues preparing for the RACP clinical exam or anyone passionate about applied medicine. For full transcripts, case templates, and learning resources, visit our website or follow us on social media. Links in the show notes. Thanks for listening. Until next time, keep thinking, keep questioning, and stay clinically curious.